Hello, everybody.
Thanks for coming to Kolkata.
Hello, everyone. How are you? Good afternoon, Professor Mendelov.
Hi, good afternoon.
Hello, sir.
Good evening, Paritosh.
We will probably start at 4 o'clock itself.
Yeah.
Yes, sir. We have 5 minutes more.
5 minutes more.
Can I just ask one question?
Sir?
Yeah, yesterday I was on a Zoom meeting to people in Hong Kong, and after 40 minutes, my Zoom cut out and it said I didn't have a license to go more than 40 minutes. So I had to go back to the email and click on the link again, and it took about a minute. Will that happen today, or does your license cover me?
It will not. This is the licensed version of the Zoom from NSI. So this will. Those, if you have a non-licensed version, the limit is 45 minutes, 40 minutes. After which you start.
Now, my license is a temporary one.
Your license
But your license will cover my time, will it?
it will not affect you. Your license will not affect you. It is the NSI which conducts the webinar, so it's their license on which this runs.
That's very reassuring. Thank you.
Welcome, Professor Mandolo.
Hello. Good afternoon.
Welcome. Welcome, Professor Kale.
Hi, Ravi. How are you?
I'm good. I'm good. How are you?
All good. All good.
I think Dr. Vikram has not joined it, no?
Yeah, Dr. Vikram took the link from me just now, around a couple of minutes back.
Hello, sir. Good afternoon, sir.
Hi, Vikram.
How are you, sir?
I'm
Right.
How are you, Dr. Vikram? So we have Dr. Apnit also has joined.
I heard Girish's voice. He had joined, I think, no?
Oh, yeah, Dr. Girish is here.
So Dwarka is yet to join, right? Everybody else is here.
It's not there actually. Dr. Dawal is replacing him.
Okay, okay.
Varga had a faculty selection in PGI, I think.
Okay.
Dr. Dawal was replaced.
So the first speaker is Manas, right?
Yeah, Dr. Manas is, seems to be traveling. So I think he may not be available for the introductory remarks.
Okay.
Anyway, we're just waiting to see if he will come online. We have a couple of minutes. Ready, sir?
I think it's 4 o'clock. We can start.
We can start. Okay. Good evening to all. I am Dr. Matthew Abraham. I hope I am audible.
Yes, Matthew.
Okay. I am Dr. Matthew Abraham speaking on behalf of the webinar committee of NSI. I have great pleasure in welcoming you to the first NSI webinar of the year 2025. I have to thank the President and Secretary of the Neurological Society of India to have given all the encouragement. I shall invite Dr. Manas does not seem to be online, he's traveling. I shall invite the Secretary for his introductory remarks, after which I shall introduce the topic and my co-chair and moderator, Dr. Vimohan Rao. We shall then together introduce the panelists and the speakers for today. First, let me invite Dr. Paritosh Pandey for introductory remarks.
Thank you, Dr. Matthew. It's indeed a great pleasure to start this new year with such an important topic. And we have an array of very, very accomplished speakers, including Dr. Mendelo, who has done seminal work in this regard. And as for the NSI, we have decided to continue the tradition of doing webinar twice a month. And under the able leadership of Dr. Matthew and Dr. Kodishwaran, I am sure that it will become more and more popular and nationally and internationally. So without wasting more time, I would request you to please start the proceedings. Thank you very much.
Thank you, Dr. Paritosh, Secretary NSI, for your kind remarks. I'll first introduce the topic. Management of spontaneous intracerebral hematoma, surgical correlation, pathophysiology, impact of trials, current directions of management. Being the single most common neurosurgical operative indications, whose incidence has not changed over the last few decades, spontaneous intracerebral bleed is amongst the most important topics that deserve an elaborate and energetic discussion among neurosurgeons and neuroscience practitioners as a whole. There are several disturbing trends for this condition that requires mention. Its risk increases exponentially with age. It is more common in Asia and perhaps in India also compared to other regions of the world. The fatality ratio for this condition has remained constant over 2 decades, even though there has been a lot of technology development in this field. And when it comes to decisions regarding surgical evacuation, it has been influenced by available technology and evolving evidence. However, most often the decisions rely on the subjective factors like the changes in sensorium of the patient and experience and preferences of the surgeon. Today's discussion, I believe, will stimulate thought and debates in this field. Today's panel of experts are perhaps the most unique, knowledgeable, and authoritative that you can find for webinar. Let me first introduce my co-chairperson, Dr. Vimohan Rao. First of all, let me say I am proud to be a co-chair with my mentor and teacher, currently head of neurosurgery at Apollo Hospital, Seshadripuram, Bangalore. He has been trained in IMHANS, Bangalore, and is professor of neurosurgery at Srivitra for over a decade. He has, as in that position, he has trained a whole generation of neurosurgeons currently practicing all over the country. His work is quite remarkable. It extends to almost every field in neurosurgery. It will go to my description of Dr. Vimohan Rao will go too elaborate. To make things brief, I have to say that he's one of the greatest contributors in advancing the standards of Indian neurosurgery in the fields of vascular, skull base, and epilepsy. I request him to introduce the panelists, Professor Mendelov, Professor Kale, and Dr. Vikram Kude.
Thank you very much, Professor Matthew, for your very kind and generous remarks. Professor Matthew was my colleague at Sri Chitra for many years. He became professor and head of the Department of Neurosurgery at Sri Chitra Tirunal Institute of Medical Sciences at Thiruvananthapuram. He has been instrumental in making several innovative changes in the working of Department of Neurosurgery. He is a very accomplished and aggressive skull base and cerebrovascular surgeon, and also has a very huge experience in epilepsy surgery. I believe more than 1,000 cases he has operated in epilepsy. And he also has important contributions in surgery for insular glioma. On the whole, a very well accomplished neurosurgeon. Welcome, Matthew. Thank you for inviting me to the conference webinar. I now have great pleasure in introducing Professor David Alexander Mendelov. He needs no introduction as he is very well known to all of us as a very accomplished and renowned British neurosurgeon, specializing in cerebrovascular surgery, neurocritical care, and stroke medicine. He has held prestigious positions including consultant neurosurgeon and honorary professor of neurosurgery at Newcastle University. He has also served as president of the Society of British Neurological Surgeons and has been involved in numerous national and international neurosurgical organizations. Professor Mendelov has significantly contributed to the management of several vasospasm, aneurysms, and AVMs. His work and contributions to the field of neurosurgery have been significant as evidenced by his numerous publications and involvement in various clinical trials. He has nearly 300 publications and more than 20,000 citations, which are remarkable. He has led numerous clinical trials, including the STITCH and STITCH 2 trials, advancing our understanding of intracerebral hemorrhage, which is the topic of discussion and presentation today. Professor Mendelov is dedicated to mentoring and training the next generation of neurosurgeons, providing guidance on clinical skills, research, and career development. His contributions have improved patient care and advanced neurosurgical knowledge and inspired future generation of neurosurgeons. I have great pleasure in welcoming Professor David Mendelov to this NSI webinar.
Thank you.
I now have great pleasure in introducing Professor Sashank Sharad Kale, who is a renowned Indian neurosurgeon with expertise in cerebrovascular, skull base, and neuro-oncology and spine surgery. His career highlights include he is the professor and head of neurosurgery at All India Institute of Medical Sciences, New Delhi. He has specialized training and expertise in skull-base surgery, having worked with renowned neurosurgeons in the field. And Professor Kale has extensive experience in managing complex cerebrovascular cases, including aneurysms, AVMs, and stroke. He has several publications. He has published 245 papers in national and international journals. I hope that is correct, Sashank. And contributing to the advancement of neurosurgery. He has also authored several chapters in many prestigious books. He has supervised and mentored many neurosurgical residents and fellows, shaping the next generation of neurosurgeons in India. He also has held various positions in neurosurgical organizations, including Neurological Society of India and Skull-Base Surgery Society of India. He has held many live demonstration workshops for neurosurgeons from India and abroad, and has been the recipient of many awards and honors. He has published over 223 papers and has been cited over 2,826 times. Professor Kale, I have great pleasure in welcoming you to this NSI webinar this evening. Dr. Vikram Hudaid is a renowned neurologist and interventional neurologist with over 25 years of experience. He specializes in neurointerventional procedures, stroke management, and neurocritical care. Currently, Dr. Hudaid serves as the senior consultant and head of neurology at Narayana Hrudayalaya Institute of Neuroscience in Bengaluru. He's also been associated with the Narayana Institute of Cardiac Sciences. Dr. Hudaid's achievements include being the first neurointerventionist to perform temporary endovascular bypass, that is the solitary stent in acute stroke in India, and the first to use a stent retriever in a 6-year-old child in Asia. His center has been one of the first to use contour intrasaccular device for aneurysms in Asia. He has also been the first in India to use the Derivo Heel latest flow diverter in a live case in India. His center is also the first stroke center in India to start AI-based rapid software to identify patients for mechanical thrombectomy. And he has developed an IVT software for stroke thrombolysis in association with Dr. Mohan. He has a vast experience of more than 7,500 neurointervention procedures. His credentials in academics is impeccable. He has started fellowship program in stroke and neurointerventional interventional neurology. It's one of the few centers in India to start FNB in neurovascular intervention in India, recognized by the DNB board. He has published numerous papers in national and international journals and has presented at various conferences. Dr. Vikram Hudaid is a keen teacher and has given demonstration of endovascular techniques in several workshops. He's also a member of several prestigious organizations, including the World Stroke Organization, Indian Stroke Association, and Indian Association of Neurology. I have great pleasure in welcoming Dr. Vikram Hudaid to this NSI webinar this evening.
Thank you, Dr. Ravi Mohan Rao, for introducing the panelists. The first talk for today is basal ganglion hematoma, understanding the correlates, pathophysiology, and clinical approach, trials and beyond. The speaker is Dr. Girish Menon. Dr. Girish Menon currently is head of the Department of Neurosurgery at KMC Manipal. He was consultant and professor of neurosurgery at Sri Chitra for over 15 years. I am lucky. I consider myself most lucky to be his student. A highly skilled surgeon and great teacher, he has vast experience in vascular, skull base, and epilepsy surgery. He's a great academician, and his academic credentials are can be summed up by saying that he's the editor of the journal we all are proud of. He indeed is uniquely placed to give this talk as a stitch trial investigator in his younger days. Over to you, Dr. Girish.
Thank you, Dr. Matthew. Thank you, Dr. Ravi. Let me just start
Welcome,
off
Girish.
straight away with my. So I hope my slides are visible.
Yes, sir. Visible.
I will put it on the slideshow.
Still not in slideshow. Yeah,
Yeah,
now it's in slideshow.
Thank you. And good afternoon, Professor Mendelo.
Hi, good afternoon.
I remember the last time we sparred against each other in the World Stroke Congress at Hyderabad. And I just want to begin my talk with a disclaimer that I'm biased towards surgery in this particular area. And we had a good debate on that occasion. But let me start off by thanking the webinar committee, Dr. Matthew and Kodisharan, for choosing this topic. Because I've always felt that unfortunately, none of the neurosurgical congresses ever discuss about this common problem. And there is something like what we discuss in the health economics, the 90-10 rule in all the neurosurgery conferences. 90% of the time is devoted for problems which we usually see only 10% of instances. Whereas cases like capsuloganglionic hematomas, which we come across almost daily, are seldom discussed in neurosurgical congresses. They are discussed, of course, in stroke meetings where neurosurgeons seldom take part. So thank you, Dr. Matthew, and Codician for choosing this as the first topic for your debut as coordinators of the webinar committee.
Thank you.
And I wish to thank you for another reason for splitting this up into separate entities, like the capsuloganglionic and the lobar, and I will just explain as to why. So this is the title of the talk, which I've been giving quite often, and because of my passionate interest in this particular area, in search of the Holy Grail. And I've never had the reason to change the title, because for the last 10 years, we are still in search of the Holy Grail. The concepts, the intricacies still seem to be evading us. So I just keep retaining the same title for my talk. But today, Dr. Matthew and Codician have given me something more specific, and I shall stick to that particular aspect of capsuloganglionic hematomas, the pathophysiology, clinical approaches, trials, and beyond. So let me straight away dive into the talk. So let me start off by saying that as these are the common sites, the five common sites of spontaneous intracerebral hematomas: the capsuloganglionic site, the thalamus, the brainstem, and the lobar and the cerebellar hemispheric ones. So this is where I was again wish to thank Matthew and Codician, because I personally feel capsuloganglionic and thalamic and maybe brainstem belong to one category, whereas lobar and cerebellar need to be discussed separately. In fact, this aspect has confounded most of the trials that have taken place, including the recent Enrich trial, where again surgery was proven to be beneficial. But if you look at it, majority of the patients were lobar. So inclusion of lobar hematomas kind of dilutes the studies on spontaneous intracerebral hematomas. And I guess we should exclude these as two different entities. And the pathology and the pathophysiology is actually also different, as I would be showing shortly. Again, for anticoagulant-induced hematoma, for some reason, because of the stroke conferences and so forth are predominantly by neurologists, there is a lot of emphasis on anticoagulant-induced hematomas. And again, the trials and all give a lot of thrust on this anticoagulation and the introduction of the withdrawal of anticoagulation and antidotes for anticoagulation. I guess those also should be removed when we talk about spontaneous intracerebral hematomas. We should just concentrate on capsuloganglionic hematomas, which itself is such a controversial and a difficult topic. So I won't be talking about any of these, the aneurysms, the lobar hematomas, the cavernomas, or the bleeding diathesis one. These are some facts which all of us knew over the years, and I wouldn't be going into this again. We know surgery is debatable. We know what are the prognostic factors, but what is new in this? What is happening new in this? So straight away onto pathogenesis, and this again what I wanted to highlight. What I personally believe is something different. So the vessel obviously bleeds. There is bleeding happening, and the reason for the vessel, the bleeding happening is the vessel wall is fragile. And why does the vessel wall become fragile? Because of some cerebral small vessel disease. And what are the types of cerebral small vessel disease that happen? Most common ones is the deep perforating vasculopathy, or you also call it as arteriosclerosis or hypertensive arteriopathies. The exact pathology they describe is something called lipohyalinosis and fibrinoid necrosis. Essentially makes the vessel wall weak, fragile, and it results in bleeding. And this is commonly seen in the lenticulostriate branches. So you end up the other perforators. So you end up having these bleeds in the basal ganglia, the thalamus, as well as in the brainstem. Other common pathology which results in a fragile vessel wall and intracerebral bleed is cerebral amyloid angiopathy. And now here again, the vessel wall, the intricate pathology is slightly different. The vessel wall, why does it become weak? Because of probably deposition of beta amyloid. And now there are different, can be hereditary, sporadic, and iatrogenic. I wouldn't go into those details, but suffice to say that if you look at ICHs, spontaneous intracerebral hematomas, the lobar hemorrhage, most of the lobar hemorrhages are because of cerebral amyloid. And when I'm excluding AVMs and so forth. So all the angiographic negative ICHs in the lobes, generally because of cerebral amyloid angiopathy, whereas the capsuloganglionic bleeds are generally due to hypertensive arteriopathy because of lipohyalinosis and fibrinoid necrosis. And in fact, there are some criteria which has come now, because at times you find it difficult to differentiate whether it is hypertensive arteriopathy or whether it is amyloid angiopathy. So there is this Edinburgh CT scan based criteria to know whether it is a CA or it is otherwise. So subarachnoid extension of the ICH, apolipoproteins status, and bleeding elongated projections arising from the bleed. So these probably suggest to a cerebral amyloid etiology. But the conventional ones which we were taught as medical students, the Charcot, Bouchard aneurysms being culprits, I must say are no longer proven. And I guess we shouldn't be discussing about them either. So this is what I was telling. If you look at this different entities, the cerebral deep perforating vasculopathies relate to the bleeds in the thalamus and the basal ganglia, whereas cerebral amyloid angiopathy. So that's what I was making the introduction, that we should be discussing these two entities as different. Now coming to the etiology. Now this again is interesting. Now I'm sure all of us would have seen such instances where a classical capsuloganglionic hematoma, but the patient is a non-hypertensive. But on admission, the BP is very high. We put them on antihypertensive, send them home. They come back 3 months later. They would have, of course, in India, it happens quite often. They stop medications and they come for follow-up 3 months or 6 months later. In fact, they do not have high blood pressure at all. So here there is a non-hypertensive patient who has a classical capsuloganglionic hematoma. And when the patient asks, the family asks as to what is the cause, what is the etiology, we end up saying it is hypertension. And they say, no, we never had hypertension. We just had hypertension during the ictus period, neither before or after. So how do we explain this phenomena? So is it right in saying that all capsuloganglionic and thalamic hematomas are hypertensive unless proven otherwise? Now, this is debatable. We have arguments for and against, and these are the ones. As you said, majority of, as we all know, majority of the bleed patients are hypertensives. And in fact, in our study, which again we have published of a series of more than 1,000 patients, we had 33%, 30%, in fact, 32% patients who were non-hypertensives at admission. And but as you know, all of them at the time of admission, of course, they will have high blood pressure following the bleed. And we always know that control of blood pressure definitely reduces the risk of bleeding. What are the points against? No, as we know, we can happen in non-hypertensives. So why does it happen in non-hypertensives? And BP can be normal before and after ictus. And the other way, if you look at the other way, if you look at a cardiology OPD where we have hundreds and thousands of patients with hypertension, and I checked with my cardiology colleagues, and how often are you worried about a problem of a complication of intracerebral hematoma? They never bothered about that. They're more bothered about other end organ damages like the kidneys and sometimes the retina. So minuscule. So what I wanted to emphasize is that all the hypertensive patients, only a very small percentage of patients end up developing a intracerebral hematoma. So there is this mismatch. Majority of patients with capsuloganglionic bleeds are hypertensive, so I agree. But of all the hypertensives, only very small, minuscule percentage of patients so developed ICH. And of course, if hypertension is the etiology, I'm sure all the hypertensive patients should be developing lipohyalinosis and fibrinoid necrosis. But for some reason, only a small percentage of them develop ICH. So is hypertension a causation or an association? So I've been exploring a lot of literature on this, and if I won't go into all the details, it is proven that hypertension is a risk factor. And I will stop short of saying that it is a causation. It is a precipitating or a facilitating factor probably. And like other risk factors like age, apolipoprotein involvement, alcohol, cocaine consumption, so forth. So I would say I wouldn't put it as an etiology. It would put it as an association rather than a causation. So this is my hypothesis, or which I always, I guess many of all of us agree to that. Of course, in all these non-hypertensive patients also, what happens is there is an autonomic surge which leads to the bleed. They are not hypertensive, but for some reason at that particular point, there is an autonomic surge which results in the bleed. So what we need to know is what precipitates or what causes that autonomic surge. And the other aspect is what we have been of late doing is amongst all hypertensives, what are the predictors? As I said, only very small percentage of hypertensive patients develop bleed. So how can we predict that if I am a hypertensive, I'm going to develop a bleed or not? So we haven't reached much, but the initial report, initial studies, initial analysis of ours, we did. In fact, we concentrated on all the young hypertensives, less than 50%. And the initial, one of the interesting observations which we wish to publish soon is that of young hypertensives, the creatinine is one image. We have been looking at three end organs, the retina and the heart and the kidney. And one observation which we found was that if the creatinine is high, they are at a higher risk of having a intractable. So all hypertensives with high creatinine, there is a risk of having an ICH. So does that mean if hypertension is not the reason, should we be doing angiograms to find any other underlying vascular etiology? That answer again would be no. We tried doing that as well. In fact, in all younger patients less than 45 with ICH, we get a lot of them. In fact, we started doing angiograms, and except for patients with primary IVH, in almost 33 patients, 4 of them we found had moya and one small lenticulostriate aneurysm. But otherwise, invariably, all the ICHs, the deep-seated ICHs, young patients also, where we did angiogram, the yield was 0. So I wouldn't say that is, we would recommend that. So that was the initial pathogenesis as to what happens, what causes the bleed and what happens post-bleed. Again, all of you know the clot expands in almost 1/3 of cases. And of course, there is a lot of edema which forms around. These are the two cardinal and the most dangerous consequences of a bleed. And in fact, there is this Fisher's avalanche theory, which has been proposed to explain why this bleed expands. The mass effect of the initial hematoma may tear surrounding arterioles, causing shearing effects and bleeds. So suffice to say that it has to be prevented. A 3 ml increase in ICH volume can triple the risk of death or disability, and a 1 ml increase in absolute volume of edema can tilt the balance towards poor outcome. So at this point, I would just like to, no, I'm thinking I'll just try to hasten it up. It is all pall and gloom so far, but it isn't so. This, as shown by this landmark article by Craig Anderson and David Seffage, are two important people in this area of SICH, and this was published in International Journal of Stroke in 2024. And why did they say so? Basically, based on 3 landmark trials which have proven to be useful. But before we go into the trials, which is the third part of my topic, this kind of summarizes the management protocol for ICHs. You stabilize, you evacuate, you protect, then of course rehab and prevent. I wouldn't be talking about the rehab and prevent part of the trials related to that, but I would like to highlight and touch upon the important trials into the initial part of it. So trials and their summary. So as I said, there is a clot, and you can either have a rebleed, which increases the clot volume, or you can have edema around the clot. And what, as physicians, as surgeons, we need to do is to prevent the secondary clot expansion. And what are the trials related to this? So most important is, of course, control of blood pressure. You had the INTRACT 2, 3, 4. And INTRACT 3 is the one where, in fact, I would be highlighting upon later, which Dr. Anderson was mentioning about, which showed for the first time that it's not just reducing BP, but it is a comprehensive package of reducing BP, preventing fever, reducing, controlling blood sugar all together. When you have a comprehensive bundle, a critical care bundle, when you do that, there is a better outcome. The otherwise, other studies like the INTRACT 2 earlier and the ATTACH and all had proven that reducing BP is safer. It can prevent rebleed and expansion of clot, but does not necessarily translate into good outcome. Now, the second, how do you prevent? Second manner in which you can prevent clot expansion is by reversing anticoagulants. And this, of course, is for patients who already are on anticoagulants. You can, so that is one other landmark trial, which I would be alluding to shortly. And the third way where you can reduce the risk of the clot expanding is by starting hemostatic therapy. And here I would like to say that there are a number of studies going on, trials going on, the fastest, which are on factor 7A, the TICH2 triage and the TICH NOAC are on tranexaminic acid. And here I would like to say that, in fact, under Dr. Jairaj Pandian and the ICMR, multiple centers in India, of which we are also part. There is an Indian trial of tranexaminic acid to prevent hematoma expansion that is ongoing. So results are yet to come. The initial results, of course, has been published, but India is also on this in the role of tranexaminic acid in as a hemostat to prevent clot expansion. So I would just highlight the important as three trials, which Professor Craig mentioned in that article, which has been very promising, the Interact 3 trial. So as you say, 7,000 patients, and there's a care bundle protocol, lower the blood pressure, strict glucose control, control fever, and reverse anticoagulation. By doing this, you reduce morbidity and mortality and improve outcome. But here I must again, and there is in fact an Interact 4 trial where they're trying to reduce the blood pressure in the transport ambulance itself. That is early reduction of blood pressure. And this was the other anticoagulant reversal study, Antonexate, which again proved to be useful in reducing the clot expansion, but it is limited to a particular oral factor, those patients who are taking oral factor 10A inhibitor. But again, there is a caveat in that there has been this benefit as at a cost of having a lot of ischemic and thrombotic events like myocardial infarction and so forth. So this just a summary of how anticoagulation has to be reversed, which I don't think is relevant to this talk, but there are studies going on, multiple antidotes for anticoagulants. But as I mentioned earlier, I guess that should be a different topic altogether and not included as a capsular ganglionic bleed. That brings to the important topic of surgery for ICH, and logic says that once you take out the clot, if you can limit secondary ischemia, you can lower ICP, patients should benefit. And that is common sense and logic. But unfortunately, we all know that most of the trials so far have not proven to be useful. And the landmark study, Professor Mendelov is here, so I wouldn't touch upon that. I'm sure he would be talking about the STITCH trial in his presentation. But as he would also agree, after the publication of the STITCH trial, there have been multiple critics for that. And in fact, their own center from Newcastle with Professor himself, along with Barbara Gregson and Dr. Kameshwar Prasad, they have done multiple meta-analysis, including STITCH and other trials, and they found that surgery, after all, isn't that bad. So how do we improve upon surgery, and what are the trials focusing on now? If you look at it, it is going to minimally invasive approaches. Here again, there has been initial disappointment. You have that MISTI trial, where minimally invasive trial with thrombolysis. MISTI 3, unfortunately, was not too beneficial. You had a clear IVS trial, which again was not very positive. So, but and this is just summary of the other ongoing trials, but of this, the important one, which has proven to be useful, is the ENRICH trial. So these are 300, again, an endoscopic parafascicular minimally invasive approach for endoscopic aspiration to be done within 24 hours in clot volumes between 30 to 80 ml. And they had a different outcome assessment. It's a utility weighted modified Rankin score, which I must confess I am not too educated upon to talk upon that. But summary was that surgical arm had a better outcome than the non-surgical arm. But here again, the criticism would be that if you look at it, of the 300 patients, almost 2/3 were lobar hematomas and only 1/3 were capsuloganglionic hematomas. Lobar hematomas, as such, we know do better. So was it the endoscopy which helped, or it was otherwise? We are not too sure. The other aspect, what we're talking about, the clot and the blood products causing a lot of harmful effects. We have multiple medicines which are in the horizon, and and multiple trials which are going on. Again, these are all in the experimental phase. None of them have been proven, but I would just like to highlight some of the focus areas which a lot of researchers are targeting upon. Attenuation of iron toxicity in inhibition of ferroptosis. If you look at a lot of articles coming up out on that, endogenous hematoma resorption strategies using erythrophagocytosis by microglia and macrophages. Another new anti-inflammatories. So the role of inflammation is being appreciated, and a lot of anti-inflammatory, including minocycline, akinara. peri-hematoma edema management using glibenclamide and celecoxib. So role of, and of course, the role of lymphatic system. So there are multiple other areas which are, as all of us know, for some reason, even after evacuating the hematoma, the patients do not do well. So the blood products cause some damage. There is a cascade which happens. So a lot of medical trials going on in those areas to mitigate those responses, those side effects. So to summarize, as a surgeon, I would again summarize basically upon the surgical trial and its results. Basically, I would say surgery, the nihilistic and the negative attitude towards surgery needs to be abandoned. Surgery definitely helps in patients between 30 to 80, 30 to 60, I would put it, especially if they are in reasonable. Two small hematomas, we need not operate. Two large hematomas, comatose patients, we certainly should not operate. But in that mid-between, the equipoise group, I'm sure surgery should be helpful. And that is what recent studies and minimalist invasive approaches are proving to be. What we need to find out as basically is the right technique and the right timing. With this, I'm sorry if I have overshot my time. Thank you so much for this opportunity and looking forward to the discussion after this. Thank you.
Thank you, Dr. Girish, for a wonderful, thought-provoking lecture. Uh, the, the discussions about these topics will come towards the end. The next talk is on lobar intracerebral hematoma, understanding the correlates, pathophysiology and clinical approach, trials and beyond, by Dr. Dhaval Shukla. Dr. Dhaval Shukla, a great friend of mine for the last 2 decades, is currently the head of the Department of Neurosurgery at NIMHANS, a great teacher and surgeon. His fields of specialization are vascular surgery, endoscopic pituitary surgery, particularly functional adenomas. And note what I'm going to say now. He's remarkably skilled in intraventricular endoscopic surgery. He's a great academician, a highly practical and down-to-earth personality. Over to you, Dhaval.
Hello, good afternoon, everybody. Thank you for giving me an opportunity to speak on lobar intracerebral hemorrhage. I would like to give particular greetings to Dr. Mendelov. I hope he remembers he came in 2015 in our neurotrauma conference at NIMHANS Bangalore, and he gave an oration on 3-stitch trials. So what we are going to talk about is one of the 3-stitch trials which he gave an oration on. So Dr. Menon has already covered a lobar ICH. However, I will restrict exclusively to lobar ICH. So at the end of this talk, you know how lobar ICH is different in terms of pathophysiology, presentation, and management, and also in terms of nihilism for surgery. So I'll start sharing my screen now. So are you able to see this? See the presentation?
Yeah, we can see.
Yeah, good. So this is our institute. Like we have one of the largest neurotrauma emergencies, and we do participate in large amount of trauma-related trials. And we have also participated in all the 3 stage 1, 2, and stage trauma trials as well over last 2 decades or more. And we also had equal experiences as world over about the outcome of this hematomas, the enthusiasm with which we did initially surgeries and then stopped surgeries, and now restarting surgeries for this hematoma as the concept of minimally invasive surgery is emerging in. So, how lobar hemorrhage is different from basal ganglia hemorrhage? It's basically in terms of location. So most of these lobar hemorrhages are in lobe as it indicates. So it can be in any lobe, but mainly in parietal and parieto-occipital lobe, and associated with cerebral amyloid angiopathy, which is due to amyloid deposits in the vessel wall as well as in the brain. However, lobar hemorrhages can also occur due to arteriosclerosis, due to microvascular disease, and even due to major arterial sclerosis. Lobar hemorrhage can occur. So unlike arteriosclerotic related hemorrhage, which Dr. Menon showed, The lobar hemorrhages occur more often in parieto-occipital lobe. And not only that, they are often associated with cortical subarachnoid hemorrhage. There may be repeated previous bleed, giving rise to cortical superficial siderosis. You may see microbleeds in the cerebral gyri, which are called lobar cerebral microbleeds. And obviously, there is hemorrhage. Besides that, other findings you may see with lobar hemorrhages, white matter hyperintensities, frank hyperintensity, or just merely small spots of white matter hyperintensities, and is often associated with enlarged perivascular spaces. So these are the pointers of cerebral amyloid angiopathy, which causes intracerebral hemorrhage. So as compared to arteriosclerotic related hemorrhage, CA is associated with higher age, maybe 70 or 75 plus, and associated with polymorphism of apolipoprotein E epsilon 2 or epsilon 4 alleles. So you can see this is like arteriosclerotic hemorrhage on left side, where the black spots on susceptibility weighted imaging are in the deep gray matter, whereas in case of CA are in the superficial gray matter. So we do workup for all the intracerebral hemorrhage. These are the standard workup, symptom evaluation, vascular risk factor medication, etc. But particularly for lobar hemorrhage, you may be able to find history of cognitive impairment of dementia before the episode of hemorrhage. It is not specific for amyloid angiopathy, but if this is present, the patient is more likely to have amyloid angiopathy as compared to arteriosclerosis. So this is how we evaluate all intracerebral hemorrhage. The main contention is whether to do angiogram or not. Our CT angiogram should be done in all patients with intracerebral hemorrhage, whether it is deep or superficial hemorrhage. Besides, for diagnosing hemorrhage, you can see spot sign, which is a bright contrast enhancement spot, which is a predictor of hemorrhagic expansion. Sometimes you may be able to notice vascular abnormalities. Whenever there is presence of subarachnoid hemorrhage, atypical hematoma configuration, or when edema is out of proportion on the day one of presentation, and there are abnormal structures in the brain, then MRI also may be indicated. So besides diagnosis of ICH, it may show microbleeds, which will tell us about the pathology of the hemorrhage. If the MRI is negative, you do not know the cause of the hemorrhage, then catheter angiogram for diagnosis of AVM aneurysms and treatment of AVM or aneurysm should be done. So this is particularly true for lobar hemorrhage in younger patients. And if all examination is negative, there is a lobar hemorrhage, there is a younger patient, then you should consider repeating angiogram after 2 weeks because small aneurysms or AVM may not be detected. And even if no AVM is detected, then maybe a few months later, again do MRI to exclude cavernomas. And if cavernoma is also not detected and patient has hemorrhage in a typical location, you are strongly suspecting, then you have to do again angiogram, particularly external carotid angiogram to rule out AV fistula. So angiogram is indicated in any patient with lobar hemorrhage if is less than 70 years of age or less than 45 years, irrespective of the site of hemorrhage. In the middle age group, if the patient has hemorrhage in not in the deep cerebellar but superficial cerebellar region, and if patient shows some suspicious lesion on CT scan or MRI and angiogram is indicated, any patient has only IVH and no other parenchymal hemorrhage, then also angiogram is indicated. So this is one classical example where angiogram is useful. That this was an elderly man. He has got cerebellar hemorrhage, but we know this is not typical hypertensive cerebellar hemorrhage which will occur in dentate nucleus. It is like quite vague. So we did an angiogram and can see an abnormal vessel, and on reconstruction there is a small AVM. So this why a 70 plus year man, first time he bled due to AVM. So it is not uncommon to find AVM in unusual location of intracerebral hemorrhage evaluation. So ICH should be differentiated from anticoagulant-induced hematoma. Like this is a case of anticoagulant-induced hematoma where there will be multi-compartmental subdural space in intraventricular and multiple layering. And sometimes you can see calcific spot which will indicate arteriovenous malformation. Dr. Menon mentioned about Edinburgh diagnostic criteria for CAA. So if patient does not have subarachnoid hemorrhage, does not have ApoE4 allele, and there are no finger-like projections like this type of hemorrhage, So it is unlikely due to CAA hemorrhage, and angiography or some other test may be required. Whereas if the patient has everything like finger-like projections and there is some subarachnoid hemorrhage here, so this is more likely due to cortical amyloid angiopathy, and no further investigation is required. Whereas in between cases, you can use your clinical judgment to ask for an angiogram. Besides looking for the hemorrhage, other things one should look for is like hypodensity within the hemorrhage. If there is presence of hypodensity within the hemorrhage, this hemorrhage is likely to expand. This is a later scan of the same patient. There is hematoma expansion, and which can occur not only in superficial, even in deep hemorrhage. The same rules apply. And when there are like finger-like projection, again there is a higher risk of expansion. When there is a perihematoma different density, then also there is a higher risk of hematoma expansion. So whether hematoma expansion is more common in deep hemorrhage or lobar hemorrhage, and what is the outcome of lobar hemorrhage as compared to deep hemorrhage? So this is a secondary analysis of FAST trial, which is a factor 7 trial, comparing deep versus lobar hemorrhage. So you can see in lobar hemorrhage, there was higher rate of early neurological deterioration as compared to the deeper hemorrhages. And the baseline hematoma volume is higher in lobar hemorrhage as compared to deeper hemorrhage, and there is a risk of hematoma expansion also more in lobar hemorrhage. And it is associated with worse overall functional outcome. However, when both the confounding variables are compared, like particularly age and hematoma volume, lobar hemorrhages have relatively better functional outcome as compared to the pseudominal hemorrhages. Surgical treatment is an option. I am not dealing with medical treatment. Dr. Menon also mentioned a brief about medical treatment, that is control of hypertension, reversal of anticoagulation, etc., and management in intensive care unit. So there are various surgical treatment prescribed for basic ganglia hemorrhage as well as lobar hemorrhage both. It can be just decompressive craniectomy, hematoma evacuation through traditional corticectomy, through stereotactic method, or through endoscopic endoport method. So this is a more recent trial, enriched trial, which Dr. Menon also mentioned about the utility of surgery in intracerebral hemorrhage. So a few important things about this trial is that it did not use the traditional surgery. The traditional surgery employed in most of the centers in emergency setting, because these hematomas are treated in emergency operation theater complex. So conventional large craniotomy is done, variable thickness corticectomy is done, and hematoma is evacuated. So the post-op scan may look pretty good without hematoma, but outcome may not be as great because a large amount of brain is traversed to reach the hematoma, particularly in deeper hematoma. Even in superficial hematoma, these are not surface hematoma. Lower hematoma, you will not see the hematoma when you open the dura. You have to do corticectomy to see the hematoma. So what this trial used is minimally invasive parafascicular, like we know there is cingulate fasciculate and superior longitudinal fasciculus. So when we go through traditional middle frontal gyrus approach, with the coccus point or anterior to the coccus point, you will be traversing to superior longitudinal fasciculus. So in this approach, it is parallel to this, both the fasciculi along the long axis of the tumor for deep hematomas. Whereas for the superficial hematomas, you have to identify the closest sulcus to the hematoma and go to trans-sulcal approach. One may use neuronavigation, and you may wonder why you want to use all this sophisticated imaging and sophisticated adjunct for the surgery for a hemorrhage, which is an emergency surgery. You must remember that intracerebral hemorrhage is not EDH, where you have to operate within 30 minutes, 40 minutes, or 50 minutes to save life. Here, the initial management is medical management, and patient is in ICU. You are giving the best medical treatment, and over time, when the best medical treatment is not working, you take up the patient for surgery. So you have enough time to use these adjuncts to do navigation and to use minimally invasive approach. So here they have used Nicomyriad device, which is like a small port in the port-like device, and a sulcus is identified, and the serial dilatation is done, and the port is used, and under endoscopic vision, and it's like a tissue debrider. Hematoma is evacuated. So the hypothesis that should improve functional outcome, and it should benefit in mortality, and there should be economic benefit. So results showed that, like he mentioned, estimated mean weightage of modified ranking scale. So this is done from 0 to 1. So if it is 0, means there is no benefit at all. 1 means absolute benefit. Anywhere in between is higher benefit. In this, the overall surgery showed benefit, but in basal ganglia hemorrhage, surgery did not show benefit actually. And in lobar hemorrhage, the difference was significant. So this was the case in this trial also. This trial was like basal ganglia hematoma recruitment stopped prematurely because of futility of surgery. So out of 300, only 99 were basal ganglia ICH and rest of the 200 were lobar ICH. As the lobar ICH surgery showed benefit in lobar ICH. So again, the safety of surgery. So mortality was less in surgical arm as compared to the control arm. And when I say control arm does not mean not doing anything. As a surgeon, what we feel, if you're not doing surgery, nothing is done. That should not be the attitude. If you're not doing surgery, patient should be managed in medical ICU with the principles what Dr. Menon mentioned, the strict control of blood pressure, reversal of anticoagulation, sedation, ventilation, and intracranial pressure reducing medications. So that is called best medical management. So if you compare to that, surgery still has is safe as death chance is less for 1 month and serious adverse reactions are also less refractory. So concluding this enriched trial result in patient presenting with lobar hemorrhage, particularly lobar hemorrhage within 24 hours of mid volume like 30 to 80 cc and minimally invasive approach and hematoma evacuation provided better functional outcome as compared to best medical management alone. So other minimally invasive surgery which can be employed is stereotactic aspiration and use of thrombolytic agents, local thrombolytic agents, which will also improve functional outcome. So why when you do stereotactic, what should be the target? There should be minimum 80% reduction of ICH volume is required to show the benefit of your intervention. However, with the stereotactic procedures, only 1/3 patients achieve this target. So this is one very good example from MISTIC trial, which showed a very good evacuation. So another option is craniotomy. You can be done, or you can just do decompressive craniotomy without touching the brain. So there is one trial, switch trial, like you just do decompressive craniotomy, don't touch the brain to avoid further damage to the brain. So common sense says yes, it should reduce intracranial pressure and reduce mortality, but functional outcome is not changed. So with or without hematoma evacuation may be considered in like desperate condition to reduce mortality. So take home message is like surgery is an option. It's not it's out of scene for more than 30 cc hemorrhage, relatively younger patient without any significant medical comorbidity and mid range of GCS who when on initial management deteriorates. So these are the guidelines for surgical treatment of supratentorial ICH without interventricular hemorrhage, irrespective of the location. The main determinant is the volume of the hematoma and the GCS. Like if hematoma is too small, irrespective of location, surgery is not indicated. And if hematoma is too big, whatever surgery you do, the outcome is not going to change, particularly in comatose patient. Whereas in non-comatose patient, you may do decompressive craniotomy, may or may not evacuate hematoma to salvage life. Whereas in mid-range volume of ICH, again in comatose patient, no advantage of surgery, and in conscious patient also may no advantage of surgery. Again in mid-range, surgery should be done with minimally invasive techniques. So this Dr. Abhinit maybe cover about recent advances in the surgical approaches to ICH. I'm skipping it. So this is one such example where mini craniotomy, like this, it is a lobar hemorrhage. So no need to do conventional frontotemporal craniotomy and all. You can just do small craniotomy, use ultrasound, find the closest area to the surface of intracerebral hemorrhage and evacuate. So this is like linear incision, small craniotomy, and using ultrasound and evacuation of the hemorrhage. So this is less morbid as compared to the traditional craniotomies. And this is the post-operative result, which shows complete evacuation, hematoma, reversal of midline shift. So when we, all of us feel that surgery should be good, but why surgical trials fail? The main reason surgical trials fail is that we have not understood the problem. Problem is not what is seen on CT scan, the white spot is the only thing which we perceive as problem as surgeon, but that is not the only thing the patient's brain has. And neurosurgical patients who require urgent procedures are difficult to recruit. You require to take consent, high risk consent, uncertainty about your treatment. So, for any surgical emergency surgery trials, whether it is trauma or ICH, it is difficult to recruit patient. And then the ideal candidate and the optimal time of surgery. We still don't know who is the ideal candidate and what is the optimal time. There is a long range of GCS, long range of young, so-called young age. So we don't know who is the ideal candidate. And many clinicians, even if the trial is going on in their institute, they may still consider evacuating the hematoma on compassionate ground, hoping that they are saving lives. So why to enroll this patients in for trial? And large crossover occurs from medical management to surgical group. Like if patient is undergoing medical management, patient is not deteriorating, patient is not improving. So there will be a lot of pressure from intensivists, patient's relatives to take up the patient for surgery on compassionate grounds. So this results in a lot of crossover. So again, the sample size becomes too small and recruitment is very small. Like in Stitch 2 trial, only 9.5% lower ICH without IVH, only 3.7% of all ICH patients were recruited. So besides surgery, as a surgeon and intensivist, once the patient is out of your OT or out of ICU, he's out of your mind. So that's not true. You have to consider rehabilitation recovery, which is definite part of the treatment. And besides moving all four limbs, you should also look for neurobehavioral complications. And our responsibility does not end with doing a good surgery and intensive care. We have to prevent recurrence of intracerebral hemorrhage in this patient. So as compared to arteriosclerosis, CA associated with hematoma, that is lobar hemorrhage has higher risk of recurrence, particularly in older older patient, and when there are multiple small microbleeds, and when there is a disseminated cortical superficial siderosis, poorly controlled blood pressure, and ApoE2 or 4 LLE presence. So if these factors are there, you have to counsel patient. He is at higher risk. He or she is at higher risk of developing hemorrhage again, and has to periodically follow up. So one has to prevent intracerebral hemorrhage as it is deadly. So blood pressure control, avoiding heavy alcohol use, and supervised training and counseling, psychosocial education should be provided, and caregiver support should be provided. So take home message: ICH is deadly, and in patient with suspected stroke, perform a rapid assessment, do a glucose, non-contrast CT, angiogram if required, and do surgery immediately for IVH cerebellar hematoma, which is not part of the topic, but there is no controversy that IVH with hydrocephalus patient requires CBD, and cerebellar hematoma with unconsciousness and hydrocephalus patient requires surgery. So that's all. Thank you.
Thank you, Dr. Paul Shukla, for a wonderful talk and for suggesting that the trials fail to show benefit because the most ideal patients cannot be included into a trial for logistic reasons. The next talk is Surgical Technique, Modern Trends and Innovations by Dr. Abhinit Sasidhar. Abhinit is Associate Professor of Neurosurgery at NIMHANS, a promising young neurosurgeon, a very good surgeon and very good teacher. His fields of interest are endoscopic and open skull-based surgery and also radiosurgery. Over to you, Abhinit.
Thank you, sir. Thank you for the introduction. Sir, is my screen visible, sir?
Yeah, you are visible.
Once again, I thank everyone for this opportunity to present this topic in front of Dr. Alexander Mendelo. I hope, as personally, that I would gain a lot from this talk and clarify my doubts as a neurosurgeon as well. Thank you, sir. Jumping to the topic, it is the second most common type of stroke, accounting to almost 10 to 50% of all stroke cases, with a disproportionate amount of mortality and morbidity. Now, what the surgery, before I talk options. What are the goals of acute care? I would just to go about some background information. Now, when the patient comes to you, we first think about preventive measures, preventive of hemorrhagic extension, monitoring for elevated intracranial pressures, managing the neurological and medical complications, antithrombotic medications, which are to be accurately discontinued and reversed, and the blood pressure management before we take up for surgery. That is, if the systolic BP is between 150 and 220, then there should be a rapid lowering of systolic BP to 140 at least before, that is provided the patient remains clinically stable. And if it is a very high systolic BP of more than 220, then we rapidly lower it below 220 and then slowly then bring it down up to 140 or 160. Coming to other management like reduction of ICP, as we know, one is the osmotic therapy, other one is ventricular drainage methods. Now, going about identifying the patients for emergent surgery. As we all know that cerebellar hemorrhage, there is no much debate or discussion. It is very straightforward. That is it is a greater than 3 mm or it is a more than 15 centimeter cube of volume. Plus with other associated factors like brainstem compression, hydrocephalus becomes a very clear-cut indication for surgery. One more clear-cut indication is presence of interventricular hemorrhage with obstructive hydrocephalus. So this EVD it becomes a very clear-cut plan for these kind of patients. Now, only debate or whatever doubts we have is regarding the supratentorial hemorrhages, in which it is not very clear of which patient will benefit and will not. And most of us, we approach by an individualistic approach based on the patient's prognosis with or without surgery. Now, what are the preventive measures we can do when patients have some have clear-cut indications and some do not have clear-cut indication, and they have to be observed. It is not a one-time decision. It is a constant clinical assessment and decision making. So, while we do a medical management, what are the things we have to take care about? One is the head elevation, sedation of the patients, antibiotic medications, positioning of the head and neck to facilitate the cerebral outflow. Supportive measures like isotonic solutions and maintaining electrolyte balance. One more thing is regarding ICP monitoring. Many studies have tried ICP monitoring, but both invasive and non-invasive have not shown to be very effective in monitoring such patients. Mainstay of surgical options. One is the ventricular CSF drainage, craniectomy with hematoma evacuation, and third is the minimally invasive clot evacuation. Now, main aim is to reduce the CSF pressure and the intracranial pressure, that is. So most often we see in thalamic hemorrhages with third ventricular compression or cerebellar hemorrhage with fourth ventricular compression, or when there is a IVH, the EVD always helps. The guarded use should be done in cerebellar hemorrhage because there's a significant risk of reverse herniation. So either a partial or a controlled drainage, or the drainage along with surgical decompression becomes the choice. So cerebellar hemorrhage, as I said before, the indications are among the three hematomas are quite clear. That is a 3 centimeter in diameter, more than 3 centimeter with volume of 15 cc with brainstem compression. Then it becomes a very easy choice for surgery, and it's been proven to be beneficial. Now, the procedure of choice is craniectomy and hematoma evacuation with uroplasty. This is one of the studies which shows the benefits of early hematoma evacuation with cerebellar intracerebellar hemorrhage. As I said before, when there is a hematoma, it was seen that when there is a hematoma less than 12 cc, then the surgical morbidity becomes more, and the favorable outcome are very less. While it's when the hematoma is more than 15 cc, more often it is seen to be a favorable outcome. Now, coming to the topic supratentorial hemorrhage, in this there is, in spite of all the trials, all the studies which we have seen and we have gone through, there doesn't appear to be a very clear-cut decision regarding which patient will improve with surgery, which patient will not. As the speakers before me have said, that in a lobar hematoma, most of the trials have shown benefit. But when it comes to basal ganglia or thalamic bleeds, it is still, not proven. So now with the newer techniques like minimally invasive techniques, we hope that the surgical morbidity which is associated with craniotomy is less, and then the functional outcome increases. This is one of the guidelines which is put forth by the American Heart Association, which deals with the intracranial hemorrhage as such. So with reference to supratentorial hemorrhage, large hematomas and hematomas refractory to elevated ICP, they have recommended to go ahead with surgery. Further clarifying that, they have said that the surgery is not for patients who are either fully alert and who can be, clinically monitored, and it's neither for those patients who are deeply comatose. Now, patients with again severe morbidity or severe pre-morbid conditions are again poor candidates for this kind of hematoma evacuation. So where surgery is justified or can be considered is one is a large volume causing mass effect, maybe more than 30 ml. Recent onset of hemorrhage that is less than 24 hours, ongoing clinical deterioration, and one is other than is the large lobar hematoma in which the functional outcomes are seem to be beneficial. All these indications are again with the caveat that the patient has to be suitable for the surgery, and the surgery should have the clinician's decision should say that the surgery has a beneficial, benefit following the procedure which he undergoes. Now, what are the things in favor of less aggressive therapy? One is concomitant medical problems, advanced age. When the clinical condition is stable, then we again tend to be less aggressive and not consider for surgery. There is a remote onset of hemorrhage, or then the hemorrhage in a very deep-seated area which is not very accessible for clot evacuation. So coming to the surgical techniques, these are the techniques which are there. One is the open craniotomy with hematoma evacuation. One is the mini craniotomy with endoscopic hemorrhagic aspiration. Other one is with along with aspirin, fibrinolytic installation of fibrinolytic agents to allow dissolution of the hematoma. And other method is stereotactic aspiration. These are the broad surgical techniques which we see. Now, among minimally invasive techniques, there will be a lot of options regarding the choice of devices, but their principle remains the same. That is a safe access into the clot cavity through a non-liquid cortex, and aspiration either directly with irrigation or direct aspiration, or mediated by fibrinolysis and thrombolytic agents. Coming back to this guidelines of spontaneous interstitial hemorrhage by the American Heart Association, one point which I particularly want to stress upon is what they have. This is back in 2002. What they had clearly told us. One is that minimally invasive approaches for supratentorial definitely has demonstrated a reduction in mortality. Other one, what they have told is that when there is a lobar hematoma, then there will be an increase. There is definitely a functional increase in functional outcome. I would not go through the stitch trials. I'd just like to say very few words about it. That actually the speakers before me have already spoken about this. That in this, whatever the conclusions were, that it is only because of the substantial crossover rate, whoever had opted for conservative management later crossed over to the surgical evacuation. That is around 26% in the stitch 1 trial, and also in the stitch 2 trials there was a high crossover rate, and that is why we had I think we are not very clear on who are actually getting a good outcome at the end of surgery. Just coming to this briefly about the ENRICH trial as well, because now in this directly deals with the minimally invasive surgery. So minimally invasive surgery with standard management versus standard management alone, and benefit at the end of 180 days. So what this says that is that definitely they had seen that the mortality was less in the group where the hematoma evacuation was done through minimally invasive methods compared to the standard management. And one more thing is that early evacuation has better outcome. These are the two points which I would want to stress upon. So this is the other trial, the MIST-3 trial, in which they had evacuation of the hematoma was along with fibrinolytic therapy, and this did not show. This in spite there was a good reduction in clot size, it did not show that functional outcome was better. Now this is one of the newer devices. I think this was initially approved back in 2017, the Artemis device, which is a device which is a minimally invasive device which is introduced to a port into the clot, and it has the ability to suck and irrigate the clot and continuous suction. And this was approved, and it was the trial also is ongoing. And there are a few. I just want to show a short video about this, which is in the public domain. Again, as I said, compared to the other minimally invasive method, the principle remains the same. Safe entry into the clot through a non-eloquent cortex with the port. Followed by the introduction of the device, which has suction and irrigation methods as well. I found a few early studies regarding this device. There was a retrospective review done about 6 patients for cerebellar ICH, which showed that there was less procedural related complications, and it just proved that it is a reasonable and very safe and effective way to evacuate the hematoma in case of but it was a very small study, retrospective study involving only 6 patients. One more trial which was done in China. This was the MISIT trial. It was a minimally invasive evacuation of hematoma with a large volume 733 patients. Even in this, they had into 3 groups: the endoscopy, aspiration, and the craniotomy group. In this trial, the conclusion was that the stereotactic aspiration, CT-guided stereotactic aspiration, had slightly better outcomes in terms of functional outcomes in these hypertensive intracranial hemorrhages. I'd just like to play a video. This is a surgery done in our institute. This video is courtesy Dr. Dhaval Shukla, my previous speaker, and I will just. This is a short video showing the evacuation of hematoma, intracranial hematoma, using the endoport technique.
However, in selected cases where the patient is young and has moderate size hematoma in mid-range GCS and who does not respond or worsens on medical treatment, surgery is an option. Whenever surgery is employed, a surgical technique which is minimally invasive leads to minimum reduction of residual hematoma and not in thalamus or ganglion rupture, and avoiding arteries and venous coagulation is preferred. One such technique is endoport assisted endoscopic technique for evacuating putaminal hemorrhage. This employs a small pre-founder craniotomy and insertion of the sheath along the long axis of the hematoma. This is one such case of putaminal hemorrhage who deteriorated on medical management and underwent endoport endoscopic assisted evacuation of the hematoma. The endoport was inserted after doing a small corticectomy, and the endoscope was introduced. On introducing the endoscope, one could see that the blood clot, which is still little liquidish, has come out, and this blood clot is sucked using gentle suction, making sure that no coagulation is used unnecessarily. The suction is continued till the brain parenchyma is seen. Once the green parenchyma is in, the control section should be controlled further in lower settings. So it does not suck the green parenchyma but sucks the hematoma in the deepest part of the hematoma cavity, where the deepest portion is sucked and no bleeding is happening from there. After evacuation of entire hematoma, the cavity is instilled with active hemostatic matrix to prevent recurrence of bleeding in the hematoma cavity, after which the drawn.
That is the end of the video.
Over and selected.
I'd like to conclude by saying that, yeah, even though that the surgery plays not a very major role, I think the surgeon's role should be a very important role in management of ICH. And with the upcoming indications like minimal invasive hematoma, the role of surgery will hopefully further increase and prove beneficial. And as Professor Dhaval Shukla already told, that why the trials prior to this did not give beneficial outcomes for surgery, but in the future with these newer techniques, I think they will definitely the trials will be planned better with lesser limitations, and we'll get more knowledge regarding this evacuation of hematoma through minimally invasive techniques. Thank you. It has been an honor presenting before you, sirs.
Thank you, Dr. Apijit, for a wonderful talk. Now, let me call on Dr. Bimon Rao to invite the panelists for their contributions.
Now, we are about to hear from Professor Mendolo. We are waiting eagerly to hear his special guest lecture. Professor Mendolo, please go ahead and give your talk.
Thank you very much. Can you see my screen?
Seeing you, but not the screen, sir.
It has not yet come.
Does that come up?
Yeah. Metlo, your screen is seen, yes.
Yeah, it's seen.
Okay, so you can see the screen. Well, thank you very much for your kind invitation to speak at this webinar. And I must say, I've been very impressed with the three previous speakers who've covered basal ganglia, lobar hematomas, and surgical techniques. They've really covered most of the things that I have to say. However, I think it's my opportunity to make my disclosure, which is that I'm addicted to evidence-based medicine. And we have seen some good evidence presented this morning, but I'm going to stress most of the things I'm going to say are based on clear-cut evidence. And you can find it in all sorts of books. These are lots of them: evidence-based neurosurgery, neurotrauma, evidence-based stroke, evidence-based neurology, neuro-oncology. And there are even books that criticize evidence-based medicine. But I'm very much addicted to it, and I'm going to use this as my disclosure. Beginning with the first use of evidence-based medicine by Archie Cochrane in the 1970s, when he developed the concept of his Cochrane database, which was founded formally in 1993. And it is the best source of healthcare evidence for whatever you want to look at, whether it's dermatology or neurosurgery or intracerebral hemorrhage. It's there, but it is slightly slow. It takes 2 to 4 years for it to come to fruition. Then David Sackett produced his little book on evidence-based medicine in 1997. It's a lovely little pocket book, and he divides evidence-based medicine into evidence-based diagnosis, evidence-based treatment, and evidence-based prognosis. And I'm going to talk only about evidence-based treatment this morning. Now, in the UK and the USA, it was initially the prospective randomized controlled trial, which I may please abbreviate to PRCT, which was class 1 evidence, but then later systematic reviews and meta-analysis of high-quality PRCTs became class 1A evidence, a level slightly higher than the trial alone. And in the UK, we have the National Institute of Clinical Excellence, or NICE, and they produce guidance on all sorts of things, and it's based on an expert committee's opinion derived from evidence-based consensus. By contrast, the American Heart Association usually classifies evidence-based medicine according to the size and certainty of the treatment effect. And many of you will have seen these kind of tables in the AHA guidelines, where you can have on the y-axis here the level of evidence, the certainty. So level A, best is meta-analysis from multiple clinical trials of good quality. And then the size of the treatment effect, class 1, the big benefit, and class 3, no benefit or perhaps harm. So that, based on that, these were the most recent guidelines that have come from NICE and from the American Heart Association. So in the UK, they came out in 2019 with NICE guidelines for acute stroke, and there's a section on intracerebral hemorrhage, which was updated in 2022. And it's a little bit wishy-washy, I have to say. You look at 1.94, people with any of the following rarely require surgical intervention and should receive medical treatment initially. And they give a number of things. I'm not going to go through the details, but it's not really clearly evidence-based. And the American Heart Association guidelines, which we've heard from just a few minutes ago, but with regard to craniotomy, they end up saying for most patients, craniotomy for spontaneous intracerebral hemorrhage remains of uncertain benefit compared with medical treatment alone. Now, I'm hoping in this short presentation to show you that there is a role for surgery. And at the end of the day, the question is whether we can afford to implement surgery for intracerebral hemorrhage using the various techniques. So let's begin then with the question, which is surgery beneficial for patients with spontaneous intracerebral hemorrhage? And this has been going on for over a century. The first PRCT was reported by Wiley McKissick back in 1961 and showed no benefit from open surgery. In fact, it was harmful. Then the second PRCT was published by Lutz Auer from Graz in Austria in 1989, and there was a significant reduction in morbidity and mortality with endoscopic surgery. And Lutz Auer was a very meticulous surgeon who used the endoscope. He was the single operator in the trial, and because he showed such a striking contrast with what Wiley McKissick had shown, many people dismissed his result as unbelievable. However, as you will see, perhaps he was the forerunner. And by 2013, there had been 15 PRCTs of various forms of surgery, and meta-analysis by then had already shown an overall small benefit from surgery. Now, this update I'm going to give you today is about supratentorial, non-aneurysmal, spontaneous intracerebral hemorrhage. I'm going to use the acronym SNASH, supratentorial, non-aneurysmal, spontaneous intracerebral hemorrhage. And the reason for confining my remarks to treatment of SNASH is these other conditions don't fit into the formula I'm going to talk about, because aneurysmal ICH has been shown to be better treated surgically in a PRCT by Heiskinen in 1988. And in his conservative group, the mortality was 80%, and in the surgical group, it was 27%. Not unexpected. Intuition would tell you that that's right for aneurysmal ICH. And also because traumatic ICH has been separately evaluated in the Stitch trauma trial, and there are many centers in India that participated in this trial. And also because cerebellar hemorrhage is complicated by hydrocephalus, and that may need drainage in its own right. So it's very difficult to be dogmatic about cerebellar hemorrhage because the hydrocephalus evolves, and it may take 6 or 8 or 12 or 24 hours for the hydrocephalus to evolve, and that will change the clinical picture and the need for surgery. And also there's been no prospective randomized controlled trial of isolated cerebellar hemorrhage so far. So then let's go to what we do know. And in 2013, when we published the Stitch trial, we published this meta-analysis of the 15 PRCTs that had been published at that stage. And you all know these forest plots. Here at the top, you see McKissick, 1961. The line of 1 is where there's no effect. To the right of the line favors medical treatment. To the left of the line favors surgical treatment. So you can see here, McKissick showed harm. The little block tells you the size of the trial, and the line tells you the 95% confidence interval. By contrast, Lutz Auer, when he published his endoscopic trial in 1989, showed a benefit which was almost significant, not quite. You see the 95% confidence interval just crossed 1. Then Juvela from Finland published results very similar to McKissick, and so on. The trials went on, and we published our STITCH trial, the first one, which included 1,000 patients who had both deep and superficial lobe hematomas. And there were 1,000 patients, and you see there's a very slight benefit, not much, and the confidence interval crosses the line. We then published the STITCH 2 trial in 2013 with this meta-analysis. You can find it in the Lancet. And there's the STITCH 2 trial, slightly better. These were lobe hematomas because we found that in STITCH 1, the lobe hematomas did well, the deep-seated hematomas did not do well. So we focused now on the lobe hematomas in STITCH 2, and there were 600 patients altogether. And when you look at the meta-analysis, the triangle at the bottom tells you the overall effect. And you can see the odds ratio is 0.74. Remember that figure because we'll come back to it at the end. 0.74. Those are the confidence intervals. But the p-value for the overall effect was 0.0001. 3 zeros 1 back in 2013. So actually, that meta-analysis showed at that time that you were better off with surgery, but only a little bit better off. And that comes to the number needed to treat, which I'll come to later on. Now, if we look at the prospective randomized controlled trials that have been published since 2013, here are 6 of them. And just to quickly go through them, the ISIS trial was endoscopy using an endoscope. CLEAR 3 trial was ventricular hemorrhage with a small ICH allowed up to 30 mils. The MISTY 3 trial was topical thrombolysis through a catheter to liquefy the clot. The ENRICH trial, the game changer, which we've heard about already, he was using this little port, which showed a significant benefit, but we'll discuss that in a moment. The SWITCH trial is a Swiss decompressive craniectomy trial where they took some of the clot out and decompressed. And the STITCH trauma trial was for head injured patients. Now, of those patients, these 3 with stars were not SNASITch trials. They weren't supratentorial spontaneous non-aneurysmal intracerebral hemorrhage trial. So let's quickly look at those, and then we can look at the 3 others, which were SNASITch trials. And then at the end, I'm going to mention the 2 most recent trials. We've heard about one of them, the Noel Pitak trial from Finland, from Thailand, and the ZOO trial from China, but all about endoscopy. So if we begin with the non-SNASITch trials, CLEAR 3 ventricular hemorrhage, published by Dan Hanley. They put a catheter into these patients, 500 patients. Half of them had the catheter unblocked with doses of alteplase, and the other half had the catheter unblocked just with saline. And there was no difference between the 2. The difference between 48% and 45%, very slight benefit from the alteplase. So ventricular hemorrhage, no benefit from adding topical thrombolysis. The SWITCH trial, the Swiss decompressive craniectomy trial, published last year in the Lancet, showed a benefit from decompression, 44% having a very poor outcome compared to 58% with medical treatment alone. But the trial was stopped at 197 patients by the funding authority. Disappointing, but the same thing happened in our STITCH trauma trial, which is not a SNASITch trial, and in STITCH trauma, which we published in Journal of Neurotrauma in 2015, there was a 37% unfavorable outcome with surgery compared to 47% with conservative treatment. So a very strong effect, 10% absolute benefit, but only 170 patients. We had wanted 800, and the trial was stopped early because of withdrawal of funding because we had not been able to recruit fast enough. So sadly, that trial was stopped, but it did show a significant reduction in mortality and a trend towards better functional outcome. But because the numbers are too small, it wasn't significant. So that takes away the non-SNASITch trials. Let's look then at the SNASITch trials and the ones starting with STITCH 2, which we've already talked about. I'm not going to say much about it, except that we know that the mortality was reduced at 6 months from 24% to 18% with early intervention for lobe hematomas. And here are the functional outcomes. I'm going to show a number of these little block charts. At the bottom here is conservative treatment, and above it is the craniotomy, which was the main procedure in STITCH 2. And you can see death was reduced and the number of functional outcomes slightly increased. The difference was 3.7%. That's between 59% and 62% poor outcomes. So a slight benefit, but it wasn't statistically significant. We did, however, manage to get a 5-day CT scan in all the patients in stage 2. So we have the end of treatment volume, which I'll come back to. Since then, the other SNASH trials were this ISIS trial by Paul Vesper from San Francisco, where he used an endoscope. It's a small trial, 54 patients, 14 treated surgically and 40 medically. There were 4 controls from the trial, and they used 36 from the simultaneously run MISTY-3 trial. And what they showed was that the result of endoscopy had a 43% favorable outcome, ranking 0 to 3, compared to 24% in controls. So quite a big difference, p-value of 0.19, so not quite significant. But look back at our trial, which everybody had dismissed a quarter of a century before. Endoscopy was much better, but also not significant, 44% with endoscopy compared to 26% with medical treatment. Almost the same as Paul Vesper showed. And if you put these two together, we will see that there's a significant effect from endoscopy. Both small trials at that stage. The next one after the meta-analysis of 2013 was the MISTY-3 trial by Dan Hanley from Baltimore. And many of you participated in this. There was a catheter put into the clot, and every 8 hours it was irrigated with alteplase to try and remove the clot. It was successful in reducing the clot volume to about 15 mils. And here you can see the outcomes with the Glasgow outcome score, the bottom one, and the one above it, the Rankin. And you can see the lower histogram is medical treatment, and above it is the MISTY treatment. And although the death rate was reduced, the number of favorable outcomes with GOS was not significant. And with the Rankin, similar, obviously the deaths are the same, but slightly more Rankin 0 and 1s, but no significant benefit overall from the MISTY procedure, unfortunately. Then came the game changer, and you've heard about this, the ENRICH trial from Emory in America. Dr. Pradilla and Ratcliffe published this one, and they used this device, the brain path made by Nico, which is a little kind of speculum type thing, disposable, plastic, clear plastic, with a trocar of different sizes and diameters. And the trocar has a little screw at the top of it, so you can attach it. You see on the right at the bottom here, the self-retaining retractor, your Layla retractor, or whatever particular retractor device you use. So you can attach this little device to the retractor to keep it nice and still. The trocar is then removed, and you can suck the clot out under vision through a mini craniotomy. And they showed a significant benefit overall. So it's a game changer in that it was the first trial that showed statistical significance for SNASH patients. However, the technique they used was slightly unconventional. It has been used in other strokes before. And here's the Rankin. Bottom is controls, and above it is surgery. And you can see the death rate is reduced. And as you know, the Rankin goes from 0 to 6, 0 being normal and 6 being death. And they used, as we've heard before this morning, the utility-weighted modified Rankin, where they reverse the order so that 0 is death and 1 is normal. And they identified points along the scale from 0 to 1, and their statistical analysis showed this statistically significant benefit. So ENRICH really shows the way forward, I think, with a small craniotomy, minimally invasive, not totally minimally invasive, but less invasive than a big craniotomy. So now if we take these modern era trials, the 3 most recent trials since the 2013 meta-analysis, which I showed you, and add them to STITCH, which also fitted in because there was an end of treatment volume measurement on CT scan. And the Rankin outcome at 180 days was measured, and these trials fitted the criteria for high quality as published by Rustam Al-Salman from Edinburgh. And here you can see the meta-analysis. At the top here, if you take the Rankin 0 to 3 dichotomously split from Rankin 4 to 6, and you can see here the STITCH 2 trial at the top, then the MISTY 3 trial, then the ISIS trial and the ENRICH trial, and they all show a benefit, but all of them show that the 95% confidence interval crosses the line of 1. So no one individually statistically significant. This is using ranking 0 to 3 dichotomous rather than the utility weighted outcome, which ENRICH published. And you can see here the little triangle shows there's a benefit, and the benefit is 0.61. And the p-value for that, with a ranking 0 to 3, was 0.05. So just on the borderline of significance. But if you put the dichotomy at between ranking 0 to 2 versus 6, the p-value is 0.02. And if you take mortality, the p-value is 0.003. So these 4 modern era trials also show a trend towards benefit, and with meta-analysis, it's on the borderline of significance. Now, what I want to show you is the end of treatment volume, and starting with the Stitch 2 trial, we've published the volume at the end of treatment, and this is the percentage change from the baseline scan. And this is the Glasgow outcome score, death in black and good recovery in green. This red line here shows when this clot starts expanding. So the top line is an increase in volume on the 5-day scan, and then a 1 to 20% increase on the 5-day scan. And then below the red line here, you have a 20% reduction, 20 to 6 to 50%, 50 to 80%, 80 to 92, 92 to 99, and 99 to 100% reduction. And what you can see from this is that the more clot you take out, the better the outcome, the lower the mortality, the bigger the number of favorable outcomes. So it's clear from Stitch 2 that the more clot you take out, the better the outcome. And that was echoed if you look at these 4 modern era trials. Look at the end of treatment volume here, Stitch 2, Misty 3, ISIS, and ENRICH. ENRICH had the lowest end of treatment average volume of 7, and has shown the best result. If you look at the mortality, though, in all the 4 trials, it's about 24%. And with the treatment, whichever one you use, it's about 18%. So there's about a 6% reduction in mortality with these 4 modern era trials. So the effect is small. It's not a very big effect. So if we're going to go for end of treatment volume, how do we get there? Well, I think probably endoscopy. I've put a question mark because it's not absolutely solved yet. Aspiration may be just as good, either free or image guided, with CT, MRI, or ultrasound, and pre or intraoperative ultrasound. Topical thrombolysis with Misty, well, that didn't really help. There was a reduction in volume, but it wasn't very much. Craniotomy, large or small, well, the small image guided one seems to be the way forward, and ENRICH certainly showed that with the brain path by Nico and a small craniotomy, there was a significant reduction. Then perhaps the most important thing is that individual careful surgery with perfect hemostasis and a post-operative check scan will give you the best result with a low EOT volume. And also, as we've heard from some of the other speakers, attention to hemostatic mechanisms, care bundles, as Adrian Parry-Jones has shown, with good ITU, stroke unit, blood pressure control, correcting hematology and rehabilitation is also important. Now, I just want to end up with 2 endoscopy trials which are not PRCTs because there was no control group. And it's a shame they didn't have them. This is the trial from Thailand, which was published in 2023. And they compared endoscopy with craniotomy. And the favorable outcome with endoscopy was 48%, close to Lutz Auer and Vesper's results, compared with 36%, and not quite significant, p.07. And then if we look at the other recent trial from China, the Masich trial, they had 3 groups, again, no control group, so we can't put them into the same meta-analysis as the others. But they compared endoscopy with aspiration with craniotomy. And the favorable results were 33% with endoscopy and aspiration, and only 22% with craniotomy. And that was significant, the difference between those and craniotomy, 0.017. So it seems that endoscopy and aspiration, stereotactic or even freehand, was better with craniotomy. And then finally, there has been a meta-analysis of minimal invasive treatment published by Chris Kellner from New York. And here you see the minimal intervention trial starting with R in 1989. And you can see that they all lie to the left of the midline. And the overall benefit is 0.46. Remember I said 0.74 was the overall estimate for all the trials, including craniotomy. For these minimally invested, it's 0.46. And the p-value is 0.00001. That's 4 zeros, 1. So there's already highly significant evidence that minimal intervention surgery of its various forms does improve outcome. The question really is, should we all be operating? And the answer really depends on the number needed to treat. The number needed to treat is the number of patients you need to operate on for one additional favorable outcome. Now, of the 18 PARCTs that we've talked about, nearly 5,000 patients, the number needed to treat is 17. So you've got to treat 17 patients to get one favorable outcome. That's an awful lot of operating, an awful lot of expense, an awful lot of rehabilitation to get one favorable outcome. And I don't know that we can really universally afford to work with a number needed to treat of 17. However, when we look at the two trials where we've got comparison with controls, that's our and Vespa, the number needed to treat is only 5. So you're getting closer to something that we can all afford and would want to treat. And if we look at the Enrich trial, here in my conclusions down here, number 4-5, the number needed to treat was only 8. So that we're getting closer to what we would always like to do, where the implementation of surgery is a resource allocation problem and the number needed to treat is not really a problem. For example, can you think of a condition where there's a number needed to treat in neurosurgery? Well, extradural hematoma. You almost always get a favorable outcome with extradural hematoma. Maybe not quite 1, maybe 1.2, 1.3. But nobody would not treat an extradural hematoma with an NNT of 1. So I think we've got to get closer to an NNT of less than 10, and if we're going to do that. And we will have the answer in time. These are the 5 ongoing trials of surgery for ICH. Most of them minimal intervention endoscopy trials. The first 2 here, Eminent and DIST, are Swiss and Dutch multi-center trials. Then 2 American trials, the INVEST trial using the Apollo device, and the MIND trial using the Artemis device, which we heard about earlier this morning. And then finally, there's the Australian trial, the Evacuate trial, where they use the scuba underwater aspiration technique. So I think that in time, we're going to have the answer, but it's going to take a little while yet. So my concluding thought, my prediction, is that whichever type of surgery is used, and it may not be that important which type you use, it must be something that the surgeon doing it has confidence in. The aim must be try to get to an end of treatment volume as close to 0 as possible. And I think that should be our goal, whichever type of treatment we use. Thank you.
Thank you, Professor. Yeah, Matthew, please carry on.
Yeah, thank you, Dr. Mendelo, for your wonderful, insightful talk. Now, I would like to invite Dr. Sasank Kale for his observations and comments.
Yeah, thank you very much to all the speakers for taking me personally, and I think we have 62 observers or watchers for this webcast. And thank you from all of us for taking us on this fascinating ride, which showed beautifully, all the 3 or 4 speakers have showed beautifully what has happened to surgical evacuation of spontaneous intracerebral hematomas over the last few decades. And starting from Dr. Girish Menon. So what I'm going to do in the interest of time is to try and summarize in a few lines, and then leave the podium with a question, which I hope the final moderator will be able to answer. Dr. Girish told us that you operate less than 8 hours if possible. The volume is better if it is between 50 to 80 ml. The results are better if the GCS is more than 9. and there is no intraventricular hemorrhage. But he said that we are still not sure about the right technique to operate and the right time to operate. Then the second speaker said that surgery is a better option. There are some trials which show that um, surgery gives better results. The GCS, again, he said, was better if the patient is between 9 and 13. The volume less than 20, there is probably no need to operate. Up to 80 ml gives better results, and more than 80, again, it depends whether you need to do anything at all, because the patient is usually in quite a bad shape. And between 20 to 80, it depends upon the GCS. If you have a good GCS, then you have better outcomes with surgical technique. Then the third speaker showed us some beautiful videos of surgical evacuation of these hematomas. And he cautioned us about, sometimes what happens is you operate because there's nothing better to do. Many times it's um, the thought that let us try and do something for the patient, and if it is making a hole in the skull and taking out the clot, let's do it, in the hope that it gives some benefit to the patient. So we must be aware of this situation, and this emotional trauma or emotional um, difficulties many times we surgeons do land up in, and especially with families who want us to try to the last breath, do something for the patient. And that's where we have to be very careful about trying to minimize unnecessary surgery. And finally, Professor Mendelov took us on a beautiful ride, showed us all the evidence. And what he said was surgery will give slightly better results. Take out as much as possible. Take out as much as possible. I think that was one of the keys messages which Professor Mendelov has given. Try and leave no trace of blood when you finish your operation. Smaller procedures probably gives better results. And that today is probably endoscopy. And in future, there are a few trials which are coming up which may be able to give us better answers to these questions. And with these words, I would like to end my observations about this webinar. And I leave it for the last moderator to comment upon my observations, what I learned upon this from this webinar. Thank you. Thank you very much.
Thank you, Dr. Kale, for summarizing this complex subject in a very lucid manner. I would like to invite Dr. Vikram Hude to make his comments and observations.
Thank you, sir, for inviting me for this webinar. So I learned a lot. I listened carefully. So one few observations what I did, and sir concluded everything properly. So a patient comes with stroke, and we do CT and CT angio even for ischemic stroke and hemorrhagic stroke. So if it is a hemorrhage, I am leaving lobar and cerebellar apart. If it is a deep system or brain stem, depending on the sensorium, we reduce the BP, bring it down. So in all these trials, the duration of the when they did the procedure, so whether we can change, because in ischemic stroke now the trend which is coming is direct to cath lab procedure. For example, if a patient comes with the symptoms of stroke, people are shifting to cath lab, doing a CT and doing a thrombectomy if there is occlusion. So here, similarly, if there is a if we do CT or direct to cath lab, and if we see a bleed, we can reduce the BP. And can we do this minimally invasive procedure in the CT room or in the cath lab? Because in the trials, what was observed was it was as Menon sir told that it should be done within 8 hours. But in the trials, they're taken 24 hours, and few of the new trials, they're taking up to 72 hours. So whether that makes a difference, so that we need to contemplate and see. This is my one of the observations, sir. Thank you.
Thank you, Dr. Vikram. I think you have hit the nail on the head. we perhaps need a trial about the timing of intervention on a hematoma, because there is a good possibility that most of this damage would have been already done. Uh, we can have an open discussion on the different aspects. We have around 10 to 15 minutes time. I just had a question to Apit. Can you comment about the most ideal trajectory for tackling basal ganglia hematoma? I've just received a question from one of my old colleagues, from a colleague, um, what regarding a specific trajectory. I shall comment on this after you make a comment on the ideal trajectory to tackle a basal ganglia bleed. Is Dr. Apnit around?
Hello.
Yeah, regarding
Am I audible, sir?
Yeah, what do you think would be the ideal trajectory to tackle a basal ganglia bleed?
Usually the clots which we evacuate are fairly large ones. So basal ganglia bleed through a middle frontal gyrus would be the very direct approach. In the difference is the presence or absence of IVH would make a difference. I would feel that's what one is. If there's a presence of IVH, it will be fairly simple. Otherwise, a middle frontal trajectory will be the direct access to the basal ganglia bleed.
Between the lines, if you see, most of the trials are pointing towards some form of damage created by the surgeon. Most of the trials seems to be pointing towards damage created by the surgical approach towards evacuation of the hematoma, which seems to reduce the utility of a basal ganglia hematoma removal. There is an observation that I just had to make. There was an approach suggested by many, that is through the superior temporal gyrus, through the insula. It's actually an open approach, but done direct vision, avoiding the MCA vessels, which may come in trajectory, which goes directly into any basal ganglia fluid. Can you? I would like to get any suggestions regarding that approach, a superior temporal gyrus approach, directly into a bleed. Whether and anybody suggest having any suggestions regarding the trajectory of approach towards a basal ganglia bleed? Maybe Dr. Girish.
Well, thank you, Matthew. What I wanted to, that's a very good approach, but what I wanted to highlight as I add on to what Abhinit told is, again, there are studies also, and we also have observed that it is not a homogeneous entity, this capsuloganglionic. So they have again classified into anterior medial and anterior posterior, medial lateral and intermediate variants. So it's for a true lateral one, what you told is a very good approach. So based on the location or the epicenter of the hematoma, you can alter your approach actually. So you can't have a single approach for all cases is what I want to say. So they suggested the superior temporal gyrus approach through the insula is a superb approach for an hematoma which is almost pointing onto the opercula in that area. But other approach which is in a big hematoma, the middle frontal gyrus approach, a parafascicular approach, which is actually the one which is Enrich has suggested, would be a good approach. So what my answer to that would be, has to be customized based on the epicenter of the hematoma and where the bulk of the hematoma is located.
Thank you, Dr. Girish. Are there any more questions or comments?
Matthew, can I ask Professor Mendelo? I just wanted one of the points which intrigues me, Professor Mendelo. What is your opinion about this non-hypertensive patients developing a basal ganglionic hematoma? Why does that happen?
I think it's a very good question, and there is a lot of anxiety about hypertension, and I think quite often, as you correctly pointed out, patients who have a basal ganglia hemorrhage present with hypertension, but they're not hypertensive patients. About half, I think you said, 40%. They're not hypertensive patients. They've got the Cushing response, a classic Cushing response with a reactive hypertension. And I worry about reducing the blood pressure in those patients, because you may actually, although you may prevent bleeding, you may actually reduce the cerebral perfusion pressure and increase the ischemia around the hematoma. So I think if one's going to move towards more hyperacute treatment, which is what Dr. Hude has explained in Bangalore, you have your cath lab, patient comes in, immediate CT scan, CT angiogram, and then they either get thrombectomy, or if they can get a minimal interventional approach straight away with removal of the hematoma, which is what they do now. Chris Kellner, who published that meta-analysis I showed you at Cornell University in New York, the neurosurgeon is there, and if it's a hematoma, they straight away put in an endoscope and suck out the clot. And also with that, they control the ICP. And if you've got the ICP controlled, then you can lower the blood pressure. So I think that the acute hematoma has to be, the hypertension with acute hemorrhage has to be treated in a very hyperacute way. And I can see that there are going to be places where the hyperacute treatment can take place, but it's not going to be for every unit in the country or the world. It's going to be in very specialized centers like New York and Bangalore and some of your institutes that have this facility. The other part of the question was about the cause of the non-hypertensive basal ganglia hematoma. And I don't know. I mean, I learned about Charcot-Bouchard aneurysms many decades ago, and maybe they do exist. The problem with the Charcot-Bouchard is that when they rupture, they disappear. So it's very, very hard to find them. But I don't have a clever answer for that part of your question.
Dr. Mendel, I had a couple of questions for
One
you.
more comment I have, sir. Regarding the Charcot aneurysm, one of my colleague in Bihar, he is Dr. Rahul. He is doing cone beam CT, and he is able to demonstrate these aneurysms in the perforators.
Wow, that's interesting. So that may be the answer to the question, that they as they were described many decades ago, they really do exist. I'm interested to hear that.
I had a question for Dr. Mendelo. Why do you think the reduced blood volume, it has two parts. The first question is, why do you think the reduced blood volume to an absolute, almost to an absolute zero, contributes to a better outcome? And the second part is, do you think that an early evacuation of a hematoma will reduce the possibility of further expansion? Because you may be able to achieve some hemostasis there and probably reduce the ultimate morbidity the patient faces. So two questions. First part is, why do you think the low volume is giving you a better outcome? And the second part is, and will an early evacuation reduce the volume of bleed and give a better outcome?
Good questions. I think the end of treatment volume goal of 0 should always be our goal. It's not always achievable, and often one leaves a small amount. But if the goal is to go for end of treatment volume, intuitively that's correct. In general, in neurosurgery, if you do a better job, you get a better result. So that you know, if the clot is worse at the end of your operation, if the clot is bigger, then the result is worse. So intuitively, you would expect a good operation with removal of the clot gives a better outcome. And I would add that if the post-operative CT scan shows that the clot is bigger or it's recurred, and it will occur, we know that post-operative hematomas occur, maybe 4 or 5% of all craniotomies. I think we should then go back in and take the remaining clot out in order to get an end of treatment volume which is low. So I think it's an aspiration and a goal rather than an absolute thing. But we could say that it's intuitively correct that the less clot remaining, the better the outcome will be. With regard to timing, I think it's very important, because the trials we've done have gone, as you know, up to 72 hours sometimes. In the MISTI trials, it was in order to get a stable clot, so you didn't make things worse. The early trials done by Morgenstern and Zuccarello looked at hyperacute treatment, and it was very difficult to get things done. But I think nowadays, with the hyperacute treatment of stroke, it may be possible to set up trials with a very short intervention, so that rather like thrombolysis and thrombectomy, you could classify the outcomes to 90 minutes, less than 3 hours, 3 to 6 hours, and so on. So I think for the future, if endoscopy can be shown and minimal intervention surgery in the upcoming trials shows that you could get a better treatment effect and a lower end of treatment volume, then I think the timing trials will have to come in. But I think we've got quite a long way to go before we get to those.
Can you unmute Dr. Suresh Nair? He has a comment.
Thank you. It's so nice I could listen to all of you, and especially my previous colleagues, Ravi Mohan Rao and Girish Menon, and of course Matthew Abraham, and also Professor Mendelo. I was the principal investigator from our Center for Justice Trial. To cut short, I think the point is ultra short, ultra early removal of intracerebral hematoma. Professor Mendelo addressed just now. A study was done by Morgenstern in 2001, where people who got operated within 4 hours, 40% of them rebled, as opposed to people who got operated within 12 hours. So there was that ultra early removal can produce rebleeding. I think Professor Mendelo touched that, but on the whole, what a great show by all people. Thank you. That's my comment.
Matthew, I have a question for Professor Mendelo. Sir, you were talking about better outcomes. By that, we mean saving the life or a better functional outcome of recovery from hemiparesis, or both?
I think it's both. It's a good question. I think mortality is the first step. If you can show that there's a regular reduction in mortality, which most of the trials do show, about a 4 to 6% mortality reduction, the functional outcome comes later, because one can create this large number of very disabled survivors, and one wants to avoid that. But I think as we go to earlier surgery, perhaps minimal intervention, I'm pretty sure that's going to work. We'll get better and better outcomes, lower mortalities, and in addition, better functional outcomes. Hopefully that will be the way forward.
A question for Dr. Mendelo. Do you think there is a contradiction between the end of procedure volume and the outcome of the stitch trials?
Yes, in the stitch trial, definitely. We showed that histogram, and it quite clearly shows that the lower the volume, the better the outcome. But that was repeated by the MISTI people. They compared MISTI and stitch and looked at end of treatment volumes in both, and the trend is there in both these trials. Although the overall result was not significant, you can see that the best results were the patients who had the lowest end of treatment volumes in both MISTI and stitch. And there's a paper that I quoted which shows that.
Thank you. Any more questions and comments?
Can I, Dr. Matthew, can I just ask whether somebody is watching the comments from the audience, and if there are any questions from the audience?
Yeah, there are some comments. How different? This is from Sudarshan. How different is a 9 cc small ICH bleed in a patient with GCS15 who is non-operative versus a residual bleed of 9 cc at the end of treatment? So will the end of treatment hematoma volume really matter?
So I think I had asked that question. So I think Dr. Mendelo had already answered that. So
another question is role of anti-edema agents like hypertonic saline in post-operative patients for ICH. Do you give it routinely for 12 to 24 hours post-op, or do we decide on the base of edema post-op scan? Can Dr. Dhaval comment on this?
I have already responded in the chat. Like when there is cerebral edema, as a temporizing measure, whether you give hypertonic saline or mannitol, it will be definitely useful. It's a part of aggressive medical management.
Okay, I think all the online comments have been answered. Any more? Is there no more questions? Any more questions? Yeah, Trishender Roy.
Yes, please.
Yeah, please. Can you unmute Chandana Roy?
I go rejected.
Are you there, Dr. Roy? Can somebody unmute this?
Or he can type his question if he is unable to talk.
We are unable to, yeah. No, it is not. If there are no more, can I call Dr. Ramon Rao to conclude our section and thank the all participants?
We had a very, very interesting and illuminating webinar today, where all aspects of spontaneous intracerebral hemorrhage were discussed, with a special emphasis on capsuloganglionic hematoma, as told by Dr. Girish, and as shown by the evidence-based medicine by Dr. Mendolo. We saw that there is definitely a small improvement with surgery for these patients, and with further employment of minimally easy invasive techniques, I think the mortality and the functional recovery is going to be enhanced. And as already mentioned in these talks, the timing of surgery, hyperacute surgery or acute surgery, also needs to be evaluated to reach proper conclusions. On the whole, a very great seminar, very illuminating. And as you told, Matthew, this is a topic which is not addressed much, as told by Girish also, that neurosurgeons don't talk about it much in conferences. I think with the improving results, this will become one of the most favorite topics of neurosurgeons. Thank you.
Thank you. Thanks, everybody.
Thank you,
Thank you
everyone.
all.
Thank
Bye-bye.
you.
Thank you, Professor Mandelo and the
Thank
other
you.
speakers.
Thank you. Thank you, everybody. Bye-bye.
Good night.
Thank you.
Thank you, Girish sir. Thank you, Kale sir. Thank you, Matthew sir.
Thank you, producer.